that the role of the CIO has changed totally. You know, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics.
I was the CIO for a 23,000-person health system, and one of the biggest challenges was to remain current on the technology and the trends that were going on myself.
Think of artificial intelligence as a orchestra. Right now, machine learning, deep learning is getting a lot of attention, so I sort of equate that to the string section. And obviously there are many sections to the orchestra, so someday soon, hospitals, healthcare organizations are going to be able to have amazing music.
We are seeing instances of folks popping up, us included, where we're having a primary care physician set up with the dentist in the same office.
I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record.
When we worked at Microsoft, oftentimes, you'd have crazy deadlines. People would say, look, we're not saving anyone's life here. We can't say that anymore. And we love that. It's like we can save someone's life. We can prevent a complication or a readmission by catching it.
A lot of the feedback people are hearing about former Vice President's remarks is that he was remarkably pragmatic. And then the one that I'm most excited about, he notes that the Medicare Innovation Center, which was created by the Affordable Care Act, has the legal authority to experiment with new models to engage patients for purposes of getting better valued care.
Hyper-consumerism driving everything to a digital experience, because if we don't make it easy for patients like ourselves to use healthcare on our smart devices, companies like Apple are starting to do it for us.
I think we're right on the cusp of a huge digital transformation. It'll be interesting to see how CIOs sort of address that.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 32. Today we're going to do a deep dive episode. We're going to look into the future of medicine and explore the world of exponential medicine. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. Work with a trusted partner that has been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. Before I get to our guests, an update on our listener drive. Our sponsor has agreed to give $1,000 for every additional 100 subscribers to our iTunes, Google Play, and YouTube channels. This is the last week of that. We've raised $3,000 for Hope Builders, an organization that provides disadvantaged youth the life skills and job training needed to achieve enduring personal and professional success. I've hired their graduates, and their stories really are inspiring. If we get an additional 80 subscribers this week, we can make it $4,000, which would be fantastic. You can join us by subscribing today and be a part of giving someone a second chance. Today, we are joined by a physician, scientist, and entrepreneur, among other things, chair for medicine at Singularity University and founder and chair of Exponential Medicine. I first heard Daniel at the Exponential Medicine Conference at the historic Hotel del Coronado in San Diego. If you haven't gone to one of these conferences, it really does just expand your thinking about what is possible. The next one is the first week of November in San Diego. Today, we welcome Dr. Daniel Kraft to the show. Good morning, Daniel. Welcome to the show.
Great to be with you.
Well, so let me, you amongst our other guests have such great bios. I'm gonna run through this real quick, just for our listeners. So Daniel is Stanford and Harvard trained physician, scientist, inventor, entrepreneur, and innovator. 25 years of experience in clinical practice, biomedical research, and healthcare innovation. You've chaired the medicine for Singularity University since its inception in 2008 and founded and is executive director for Exponential Medicine, a program that explores convergent, rapidly developing technologies and their potential in biomedicine and healthcare. Following undergraduate works at Brown and Stanford, Daniel was board certified in both internal medicine and pediatrics, after completing a Harvard residency at Mass General and Boston Children's and fellowships in hematology, oncology, and bone marrow transplantation at Stanford. He has multiple scientific publications in medical device, immunology, and stem cell related patents through faculty positions at Stanford University School of Medicine and clinical faculty for the Pediatric Bone Marrow Transplantation Service at UCSF. Daniel is a member of the Kaufman Fellow Society, member of the inaugural class of the Aspen Institute Health Innovators Fellowship. Daniel's done some really cool academic research. Just for time purposes, you can check that out, danielkraftmd.net. He's also the inventor of the Marrow Miner, an FDA-approved device for minimally invasive harvest of bone marrow, and founded RegenMed Systems, a company developing technologies that enable adult stem cell-based regenerative therapies. Daniel is an avid pilot and has served in the Massachusetts and California Air National Guard as an officer and flight surgeon with the F-15, F-16 fighter squadrons. He has conducted research on aerospace medicine that was published with NASA, with whom he was a finalist for astronaut selection. You've done so many amazing things, but I really have to start there. So
you missed the fact I'm a Capricorn. My favorite color is blue. I like long walks and short beaches.
I know but the amazing thing to me, I just read all that amazing stuff you've done in medicine, but I'm sort of fascinated with the finalists for astronaut selection. What does one have to do to become an astronaut these days, and where did you finally get off that path?
Well, there's no exact one path, but I always had the space and flying bug. I grew up in the Washington, D.C. area. I think I went to the Air and Space Museum probably 100 times as a kid. Actually, when I was 3 or 4 years old, I was at the very last Apollo launch, Apollo 17. I was there. I still remember that. And years later, when I was a medical student at Stanford, I did a rotation at Johnson Space Center in medical ops, and I met Gene Cernan.
Oh, wow.
Just in space and flying. I knew I couldn't be a fighter pilot because I didn't have 20/20 vision. But I kept that interest up, and I sort of actually during college, I spent a summer at Kennedy Space Center while a medical student, worked on space systems engineering with some Stanford engineers building and designing missions to Mars, got involved in the International Space University for summer during medical school. So kind of kept that space and flying passion going with, never quite losing that desire to want to be an astronaut from being a little kid, and eventually applied. And there's no exact criteria. It helps if you might be a test pilot, in the Air Force and Navy, but most of the medical corps are often scientists or engineers, not necessarily full-on aviators, and they take a whole subset. And there's several physician astronauts, and there's a lot of medical issues, particularly if you want to go back to the moon and on long-duration missions to Mars. So it was an interesting area for me to always sort of blend the interest of space, flying aviation, space. And as mentioned briefly, I didn't get to be a full-on fighter pilot, but I joined the Air National Guard as a flight surgeon, which means you're sort of the doc for a bunch of pilots, and got to be in the squadron and fly a bunch in the back seat, but got to fly the F-15s, X-16s, and get part of that world as well.
So when Elon Musk decides to go to Mars, he's going to reach out, tap you on the shoulder, and see if you're still interested in practicing medicine at Mars, I guess. We'll see.
Well, yeah, I know Elon a bit. I've been to SpaceX. It's incredibly how fast that's moving now. And there are a lot of big issues if we're going to go to Mars and have sustainable life, radiation issues, a lot of issues that you can take from space and apply to healthcare on Earth, like cardiovascular deconditioning, bone issues, radiation exposure. So it's been a fun area to kind of cross fields.
So one of the things we like to do with each of our guests is just sort of give them the floor and ask a pretty open-ended question of, what are you working on today and what are you excited about?
Well, I wear a couple different hats. I sort of interestingly it's kind of through these space connections, through going to International Space University, kind of got hooked into the early stages of Singularity University, which is su.org. And what's interesting about many folks in health and medicine is we get really good at some specialty. I'm an oncologist, cardiology, biotech, pharma, but it's often rare that you get to bridge fields. And part of my role chairing medicine at Singularity University and then spinning out this exponential medicine program is to help particularly folks outside of and inside health and biomedicine see what's happening and what the convergence is, where 3D printing might be heading, or AI, which is certainly a hot topic, or healthcare IT, or mobile, or sensors. And 10 years ago when we did our first programs, I was getting people the very first 23andMe kits or the very first Fitbits. That was now that's sort of normal. At the time, that was pretty interesting. So one of the things I'm still excited about is kind of getting this cross-fertilization, exposing folks in the healthcare world to some analogous areas, sometimes even lessons from aviation, like checklists and simulation are being applied to health and medicine in very impactful ways. And to bring people out of their silos to look at what are small challenges, big challenges, grand challenges across health and medicine, and how do we catalyze that? That's what's the theme, as you've seen at Exponential Medicine, is to bring people together from different fields, catalyze their thinking, see what's here now, and how do you think about where the puck is going to help reshape whatever issue or realm of health and medicine you're involved in. So that's one area I stay excited about. Some of your listeners might want to come to Exponential Medicine this November 4th through 7th. Exponentialmedicine.com has a ton of links to prior talks and content. Another fun thing I'm interested in, I'm launching in the next month or so, is there's the field of digital health, connected mobile health, whatever you want to call it, that is sort of becoming more and more part of healthcare. It started off kind of as a side element, but now I would argue we don't need to call it digital health, it'll be health. But I'm often asked, what technologies should I use for managing a patient's hypertension or diabetes, or what apps are there in VR for therapy? And so I'm launching in the next month or so a website, digital.health, as a new .health domain, to try and help bring together the sort of best of breed apps, devices, platforms, but also inform folks, mostly on the clinician side, what's already out there that you could be using if you're trying to manage hypertension, or what diagnostic tools out there that, connected stethoscopes or apps that might be already proven to be valuable. So that's another element I'm working on. A bunch of other things we can talk about. Those are a couple of things that are, I think, top of mind.
Yeah, so that's fantastic. So let's just dive in. So this is a deep dive episode. In deep dive episodes, what we do is we generally explore a single topic. We've done one on AI with Dr. Anthony Chang. We've done one on cloud computing with Robert Rice. Today, looking at exponential medicine, it's actually not a single technology, but it's really a confluence in advancements in a lot of different technologies that's changing the landscape. So let's just start at the beginning. Give us an idea of what exponential medicine is.
Well, the term exponential is sort of, as many of you know, the idea that things progress in some fields very quickly. Instead of linearly 1, 2, 3, 4, 5, it goes 1, 2, 4, 8, 16, 32, 64. By 30 exponential steps, you're at 1 billion. And the usual example we all get is our smartphones. Moore's law impacted these. How much computer power? My iPhone 10, is probably multifold over my iPhone 1. My iPhone 1 would feel antique today. I still actually have it in my drawer. And that was only a decade ago. So things, especially if you look back a decade, there's that famous quote from Bill Gates, we overestimate what happens in a year, underestimate what happens in a decade. It was only 10 years ago this week that Airbnb launched. It was 11 years ago that Twitter launched at South by Southwest. Only 10 years ago since the App Store. And now obviously the fortunes of Apple looks like they're riding partly on healthcare. And we've got other big players from Amazon to Facebook to many others moving in that space. So the idea is to get people thinking about the exponentials or technologies that move relatively quickly, and think about where are we in 2018, what will likely be available in 2020 or 2028. And one area that's gone past exponentials is personal genomics. 10 years ago, to get your full genome done wasn't available really commercially. Now it's less than $1,000. Probably in a couple of years will be arguably available for $100 or yes, and maybe hopefully integrated into many of the EMR and personal health records that the clinicians listening and patients who might be listening will have available to them, not just with the data, but applying, as you've talked about on prior episodes, machine learning and AI to make sense of that data and turn it into actual clinical information. So there are many things moving quickly. I think exponential can be overused as a term, but we use that kind of to encapsulate where we might want to catalyze the future of health and medicine and bring fields together, from VR to synthetic biology to robotics to drones that are moving pretty quickly.
Yeah, and we're going to look at a bunch of examples, but it really is that hockey stick. It's it's incremental, and then all of a sudden it goes up. And you gave the example of mapping the genome, and that has gone from taking a massive team and millions of dollars down to 23andMe. It's send it off and here you go. Or at least a portion of it. Or I went down to Human Longevity and Health Nucleus and did that whole thing, and within a week or so, and quite frankly, comparatively speaking, pennies on the dollar. That's exponential in terms of just having that data, having those capabilities. And the phone,
I was there as well. The most amazing part I found was I was in the full body MRI machine for about an hour. I came out and almost immediately, you probably had this experience. You saw my full body MRI and with the brain color coded, so you could quantify, what percentile your thalamus was compared to others, for example. And that, really was not available until just about a year or two ago. What's going to be available with another couple clicks of Moore's law. And while Human Longevity Incorporated or Nucleus is still a bit expensive, it's getting cheaper and cheaper. And as you blend those, they do microbiome, genome, full body MRI, digital health exhaust, combine that with coaching, as companies like RFA and others are doing, I think is the early stages of hopefully really catalyzing a shift across health and medicine.
Yeah, so exponential medicine is advances in imaging, robotics, genomics, nano technology, miniaturization, computing power, AI, all coming together and really creating this, if each one is just moving along at a certain pace, you combine all that across the board, and now you have all sorts of new capabilities. So give us an idea of how exponentials are going to address some of the biggest challenges we have in healthcare. We have, cost, access, fragmented care, care variation, even within our communities in the U.S., but care variation around the world. How does exponentials start to change that paradigm?
I think in a sense, there's lots of challenges, and healthcare is kind of like politics. It's a bit local. So, so many different healthcare systems, as might have different challenges and needs, some which are overlapping. I think where it provides the biggest opportunity is to move from, again, somewhat buzzwordy. We want personalized and precision medicine, but in reality today, we're still practicing kind of one size fits all medicine, often the same dose of statin we start with. If you're managing a patient with hypertension or diabetes, we're starting with the same drugs, trial and error, broken feedback loops, still communicated by fax machine in many cases. And so the opportunity is now to take the increasingly exponentially more available, accessible data, whether it's our digital exhaust that can be picked up by our wearables or our smartphones or our connected mattresses, and start to connect that into our healthcare system. And as you discussed in prior shows, kind of meld that information so we understand what it means. What does it mean if my Fitbit or my mattress sensor tells me that my resting heart rate's normally 55, but it's last couple of months it's creeped up to 75. Something might be happening. How do we take that baseline of data like Verily is doing with the baseline trial, or now the All of Us trial at NIH, and start to understand what are some of these new biomarkers, digital omics, social metrics start to mean, and be then much more proactive and start to shift our sick care system to more of a healthcare one, where we can utilize this sometimes overwhelming amount of data and turn it into proactive, useful information that fits into the workflow of the core of a work clinician. There's some great solutions already here today, but they're not being utilized for reimbursement issues or someone moving someone's cheese, turf battles. There's a lot of other elements beyond the technology itself, the incentives, the user interfaces that need to be put together as well.
Yeah, I'd really like to get back to that data question, but before I do that, I do want to explore a little bit more of the technology. So what I'd like to do is go through a bunch of the technologies before we get really pragmatic on how do they get integrated into the health system. And I'd love to hear you just talk about some of the things that you're seeing because you visit a lot of these startups and are talking to some real innovators. So I'm gonna rattle through some different areas I'd love to hear you talk about a little bit. So let's talk about the area of robotics. What are some things you're seeing in robotics?
So it's not new now to have robotic surgery. Intuitive Surgical has been a leader, and those have been out for a while. Still debate about whether they really improve outcomes or lower cost. But remember, that's now the surgeon still very intuitively controlling every move of that robot. And I know both Intuitive and several other new companies, Verb, which is done by Verily, and J&J, I believe, are now starting to look at how do you blend AI with robotics. So it's kind of a merger of yes, we can now do things at smaller scale inside the body and connect that to the brain and hands of a surgeon, sometimes even remotely. But now how do we inform what you're seeing through your scope, maybe layering an MRI or CT data to see where the tumor is inside the liver you're resecting, for example, or to guide someone through a surgery, doing remote mentoring or doing that autonomously, looking at analyzing videos and seeing that's where the gallbladder duct is, and be careful, you're doing a cholecystectomy. So I think there's this interesting convergence point of robotics with AI, machine learning, and now that start to record every move of a surgeon, let's say, on a particular device, to increasingly, hopefully, use that for training, and also to democratize surgical access when we can put maybe a surgical device in a more remote location with less trained practitioners. Obviously, robotics goes beyond the surgical space. There's now wearable robotics. Exoskeletons are not new, but now are being applied to enable someone who might be paralyzed from the waist down to walk. There's several versions of that, ReWalk, Exobionics. Robotics in being integrated into wheelchairs to enable stand-up wheelchair that Dean Kamen developed initially, that turned into more of a commercial device. There's lots of interesting robotic applications. Might be for someone with a stroke to wear a sort of exoskeleton to help them improve their mobility, all the way to aging in place and robotics in your home. My home, we've got 3 robots. We have a Jibo, which is fun to interact with, kind of like a Alexa with movement. We've got a Roomba to clean the floors. I've got a Beam telepresence robot from Suitable Technologies for doing telepresence with my kids. So those are things that are coming to our homes pretty quickly that can help do remote care, telemedicine, or social visits, or enable someone who's older to have augmented daily living activities. So robotics is getting exciting and more and more accessible.
Yeah, and I was at a conference where someone was paralyzed from the waist down, and they essentially put on a robotic exoskeleton, and that person got up and started walking. Now it's still bulky, it's still pretty big and pretty expensive, but that's sort of the concept of Exponentials, is that's where it's at today. But through advances in technology, you're going to see the cost of that really come down and become mainstreamed a lot quicker than it would have, say, 2 decades ago. So
yeah, well, even companies like Exobionics, they have, the initial versions were only in stroke recovery centers. Now you can send folks home with some of those wearable exoskeletons, and so they can essentially get around their house. We're seeing Ford Motor Company now, for workers, are adding sort of exoskeleton suits for certain procedures where it's repetitive or can prevent injury or help them do things at sort of superhuman strength. So it's moving across many elements. And of course, healthcare crosses everything from wellness and prevention, including workplace prevention, all the way to diagnostics and therapy, and robotics plays a role in that, including robotic diagnostics or robotics therapy. Speaking of a bit of robotic and AI blended, I just had a call earlier today with the head of the Focus Ultrasound Foundation, another area where you're sort of combining the robotics of an imaging device and focus ultrasound that can do interesting therapies, from treating Parkinson's to tumors in a non-invasive way. And that's a bit of a blend of many technologies, including kind of robotics and imaging and focused energy beams.
So I'm going to rifle through the rest of a couple more of these, but it just gives you some idea. I mean, we're just talking about robotics, and we could probably talk for, the next 2 hours just about robotics. But I'm going to hit a couple more. So Nano Technologies, what are we seeing now, and what can we expect over the next decade or so?
Well, like any field, nanotech, VR, 3D printing, they all have a bit of their Gartner hype cycles. Nanotech is one of those broad terms. There's some still amazing thinking and work to think about. We can build machines down at the level of a red blood cell and to create, nano machines at that level. I think of nanomedicine even to the point where we're already sort of doing that with engineering viruses. That's sort of nano engineering our existing biology in a sense. But as we get to sort of the nano scale, there's some interesting things that can be done, including on the diagnostic side. So Sangeeta Bhatia at MIT using sort of nanomarkers to home to a tumor, and then to catalyze an enzyme that will show up as a signal in your urine, maybe a fantastic nano approach to doing pan-cancer screening with just as simple as a urine dipstick. You can think about nanotech already coming to coding of implantable devices to prevent clotting. So it's a very broad field. And what's getting interesting is it's merging, again, this convergence with things like synthetic biology, where we can now there's digital origami, where you can literally build DNA and fold it based on how you might program it. And that's moving us to the realms of, for example, some early work at MIT and elsewhere with nano devices that can encapsulate a chemotherapy agent and deliver it to a local environment with a combination of antibodies. So lots of things coming to the nano space. Immunotherapy is essentially, I think, a form of nanotherapy, engineering T cells, CAR T cells. So we all want health and medicine to get targeted, less toxic, and the realm of nano, I think, is sort of one way of encapsulating that.
So 2 more. So augmented virtual reality. We're seeing just some really neat use cases at Cedars-Sinai. I know they're using it in other health systems. Are really using it to sort of almost reprogram the brain, as just you talk a little bit about that.
Well, I'm sitting right across the room from me. I already have my antique Oculus device from Facebook, and I barely ever use that one. It's connected to, it was $600 originally. I think it's now $200, but I had to get the $2,000 fast computer. And then just 2 months ago, I got the Oculus Go. It's the same basic form factor, but now I can take it on an airplane. It's really fun to give demos and put people on their first roller coaster ride. But work that's been done at Cedars-Sinai, led by Brandon Spiegel and others, is really catalyzing use of VR and AR and XR, extended reality, across so many different areas. If people Google up, I gave the keynote at the the Virtual Medicine Conference that was held at Cedars-Sinai last spring. And some great examples of now taking these often gaming platforms, initially catalyzed by the gaming world and the reality engines in there, to now enable you to create an environment for someone in pain, for example, to be in a cold environment, throw snowballs at penguins. And that has been shown to reduce the need for opiates for acute and chronic pain patients. There's obviously the use of VR and AR now in surgical training. Some very exciting startups from Oso VR, for example, can take an orthopedic surgeon, put them in the virtual operating room, give them the actual kit from Stryker or another orthopedic company, let them practice with essentially the actual instruments on the patient or the fracture type that they're about to do a procedure on. So I was trained in the C1, D1, Teach One world. It's going to be a future of C1, Sim1, Sim1, Sim1 until you get it right, and often simulate that exactly on the anatomy of the patient you're about to operate on. Yeah. And then there's obviously augmented reality, which can be used in a variety of ways of several interesting companies and academic groups, blending that so the surgeon can see through the body, or blend that with robotic surgery, all the way to patients to improve their gamification of recovery from physical therapy and make it much more empowering. And so I think that's a great example of a field that, 5 years ago, you couldn't have bought an Oculus type thing for $5 million. Now it's essentially $200 available on Amazon.com. And these systems are being democratized where folks around the world, you don't need to be in an academic center, or you can be in Timbuktu and be programming for these and selling them online, and even doing virtual trials that could accelerate the use of VR and AR and XR in a variety of ways.
Yeah, and you know what? The first Exponential Medicine conference I went to as a patient, I was pumped. I was so psyched about what the future looks like for me and for my children. And but okay, so at that point, I'm a CIO for a health system, and I'm just hoping beyond hope that none of my physicians are at the conference, because what happens? They come out of that conference, and hey, let's buy this, let's do this, whatever. And I think what you're seeing is, and I want to get into the pragmatic aspects of this. All of this is really exciting. A lot of the CIOs, the IT organizations, even the clinicians and the physicians, you're getting a little bit of backlash because there's so much change coming at them. So I want to talk a little bit about that. So we as patients want to go in there and say, hey, can I hook up my scale to the medical record? Can I give you my Fitbit data? Can I give you my health nucleus data? And you start to really consume this genomics data. And I've sat in meetings with physicians where they say, no more data. I can't handle any more data. I have 8 minutes to talk to a patient. I just can't. So talk to us about how are we going to overcome that? Does Exponentials offer any hope in that? I would assume that AI and really augmenting the intelligence of the physician and technologies in terms of allowing them to interact with the medical record through voice and other things are going to make them more efficient. I mean, how would that play out, do you think?
Yeah, well, that's a huge pain point, right? If to back up for a little bit, if a clinician comes to Exponential Medicine and sees some of these things, what's exciting about it is you don't need to have $1 million lab anymore. You can go and buy an Oculus or Rift or some of the other commercial platforms and start playing with them. In fact, at our early Exponential Medicine programs, we had the first Google Glass shown off by Babak Parviz, who was on Leading Glass. That inspired civil surgeons and clinicians to bring those into the operating room for the first time. So what's interesting, and I would argue that most hospitals, academic or not, should have a little innovation lab where you can buy some of these things for a couple $100 and start letting your clinicians try them and not breaking FDA or confidentiality rules, but seeing a pain point that they might be able to apply it to for surgical training, or taking a patient who's bedbound during a bone marrow transplant and putting them at the beach in a VR headset. So there's some ways to try these things out that don't need to be always fully implemented across your whole healthcare system at expense and reimbursement levels. But I think to the point about exponentials, we need sort of to integrate the design thinkers, the UI folks, user-centered design. I mean, I like, sometimes people call some of the EMRs epic fail for obvious reasons, that it's 17 clicks, I think, at Stanford to prescribe an aspirin. And I trained at the transition between paper and AMRs, and there's some benefits to both, but you don't want the data, you want the synthesized information. And so I'm hopeful as folks are evolving the EMRs of the near future that you think about the clinician. The burnout issues are real, where you can synthesize your genomic, your HLI data, your 23 information when it's relevant. So that when you're seeing a patient that's put up just in time, you're about to prescribe a statin, well, you pop up Daniel's pharmacogenomics and you might pick a different dose of simvastatin or switch to atorvastatin based on my pharmacogenomics and the data that's out there. Kind of, as Anthony Chang talks about, intelligence-based medicine, not just evidence-based. So I think there's a lot of need to blend not just the technology, but the way to meld it. And if you're a CIO or a CMO of a hospital, how do you incentivize your clinicians to use it? And can they bill for an e-visit or time looking at omics information? How could they get rewarded for prescribing a connected blood pressure cuff and using that to improve hypertension control or diabetes with a connected blood pressure cuff or a glucometer? So lots of issues in there that hopefully lessons can be learned from multiple systems and applied across healthcare around the world.
Yeah, I love that idea of, these technologies have come so far down in price. It used to be, hey, we're going to do something. It kicks off $1 million project within the health system. Now what you're saying is you could potentially do a pilot for, a couple $1,000 and then just put the right people, small pilot, see how it goes, and then scale it from there.
And there's often death by pilot. Like all these digital health companies want to come to Stanford, UCSF, or UCSD and do their thing. And there's now some folks building platforms so you could share pilot information from folks on the East Coast or Europe or Latin America. You can now do clinical trials in a sense, in lower, cheaper ways on mobile. There was a company we had at Exponential Medicine called Netable, where you can now basically, without much technical training, build an iOS app that will let you do trials and democratize it. So there's some really interesting ways to, at lower cost, test some assumptions. We now know that there is hype in digital health. There's now, not just giving someone a Fitbit is not going to make them lose weight. How do you align I like to think about it as the sort of the behavioral phenotype of a patient. So imagine your EMR actually start to pick up on, what are your carrots and sticks? How do you, when you send someone home, maybe they already have an Amazon Alexa or Google Voice, and you can use that as part of the interface to keep them on top of their meds. Maybe they like badges versus points or like dollars, and use that to help their digital nudges that show up on their smartwatch. Same thing for the clinicians. So there's, I think, some big opportunities to pull in and integrate these elements and show that they work before we roll them out at scale.
Yeah, so I do want to talk about engagement a little bit, but before we get there, let's talk about some of the data challenges. So lack of standards, governance have led to sort of data silos. And in some cases, the data is just really hard to use. And we're struggling to make the data actionable. Where should we be looking at? I mean, it's not just a technology solution, I would assume, and it's not just a CMS government solution, and not just an internal data governance solution. Is this one of the things that's holding back Exponentials and really moving healthcare forward? Or
yeah, I mean, absolutely. We're in the fourth industrial age. Many other fields have accelerated, and again, we're still often using fax machines. I think the news out this week from New Verma was that CMS wants to get into fax machines by 2020. Oh, great. What about yesterday? Or the other news from the same week that we're doing this podcast is that Salesforce and Amazon and a couple others, not Apple yet, are looking to do FHIR FHR standardization. But that's a huge issue, not with just data silos, but ways to access, to do normalization. I think the only metric that is normalized across the planet is INR for Coumadin, or measuring how thin your blood is. But many others are very different, and that creates challenges in normalizing that data and interpreting it with machine learning and AI. So, I know HIMSS and other conferences really look at that. There's still huge challenges there. I don't have the exact answer, but I think now we're seeing enough catalyzation and seeing the value of opening up portals and enabling data to flow. hopefully even the regulatory side. I think we love to hate HIPAA. It used to be about portability. Now it's almost all about privacy. And there's been many examples, and I've had clinical cases, including where the patient died with their privacy intact because you couldn't get their records released in the right timely manner. So I think we need to think, as things evolve, including on the FDA side, which they're doing with some very effective programs like the PreCheck program and software as a medical device. Think about how we both regulate and catalyze information to flow, maintaining privacy, but catalyzing a bit of what I like to think is the crowdsourced future of medicine. Just like 10 years ago we were still driving with paper maps. Now you couldn't imagine driving without your Google Maps or Waze. And part of that is we're all sharing our data, sometimes whether we like it or not, and can build that traffic map. What if we could build some of those healthcare maps to know where the bad disease elements are, or a person with a certain phenotype or genetic subtype would require a different highway.
Yeah. So let's go in this direction. So I'd like to do two hypotheticals with you. In the first, we're going to design a health system from scratch that we're going to launch in 2020, say in the Southern California market, and just say, hey, it's greenfield, we're starting over. And in the second scenario, I want to talk to you about, I'm going to make you the exponential consultant to Dr. Atul Gawande on his new role at JPM Amazon Berkshire, and just take a few minutes to understand how exponentials might be used in care and wellness of his 1.2 million employees that he's going to be overseeing. So let's start with this one. So we're designing something from scratch. It's going to have to integrate with what's already in our market. It's going to have to leverage the various things that are already present. But let's assume we just got $5 billion. You and I are going to start a new health system. It's in Southern California, and let's just dream a little bit on, where do we start to invest that money to provide really proactive care versus reactive care, continuous care versus intermittent sporadic care. And where would you start? Would it look completely different? Like we shouldn't be thinking about buildings and acute care facilities, or where would we start, do you think?
Well, if it's a full-on system, of course, you want to go from soup to nuts, from prevention, longevity, through diagnostics, therapy. So you can still need the acute care facility, but let's start reimagining what it would like when you might join that system, using what's here now and what's coming. Some of this is starting to bubble up. The fact that I can now go on my phone and get my Epic record from Stanford, and my Stanford doctor can see my digital exhaust from my smartphone. That's not necessarily being utilized. So imagine a system where when folks join this healthcare system, they get essentially a bit of the HLI RVL type element where they get their genome done. And that information isn't just a data file. It gets synthesized into your personal health record and the one that let's say your primary care doctor sees, so that when you're coming in for even your annual visit, we can look at that and help tune some of your prevention and maybe therapy. It was an interesting paper out this week from Seth Kathari, who was actually a resident with me at Mass General, looking at multiple genes for risk factors for, let's say, cardiovascular disease. So it won't be any one gene. Many diseases are multifactorial, but imagine when I'm seeing you in my clinic, I can already get a look at that genetic risk score and use that to tune whether you really need to be on a statin, or what might be your optimal prevention regimen given some of those risk factors, lifestyle elements. And then obviously, again, overused term, but patient engagement, the fact that hopefully everyone in your system can touch their healthcare how and when it fits them, right? If you're a millennial versus a baby boomer, you're going to interact differently with your technology and user interface than even if you have the same type 1 diabetes issue. So melding that, so it's not one size fits all, precision UI as well. So then just riffing here a little bit, when you have a patient with an issue, let's say something common like hypertension, they may now be not just with the usual once a day blood pressure device, it might be able to know to watch. There's one coming out from Omron, which might squeeze your wrist, or several startups doing non-invasive, almost radar-based hypertension. So you can have essentially real-time hypertension numbers and use that in a seamless way to tune often 2 or 3 different drug classes. So building in these sort of algorithms and feedback loops that continue to learn and fit into both the prevention side and disease management. So, and that requires good user interface. It requires some smart reimbursement elements. It maybe requires you to have a bit of a digital pharmacopoeia, and there are clinics like Forward and others are trying to build what's the next generation of that primary care visit look like. That's a little bit of what I would think about in terms of building a system from scratch with, on the exponential, not just building it with 2018 in mind. What kind of data elements or platforms or pipes might you need to preserve for what's likely to be here in a couple of years? 5G is rolling out in many cities, including Southern California, within the year. So what could you be doing to be thinking about 5G and 6G? Where could you be building in platform integrated telehealth, where asynchronous or synchronous care could be used, again, across the care paradigm? So those are a few things I'd be thinking about, and not just with the lens of 2018 as well.
Yeah, so some of the forward-thinking health systems, I think of Geisinger, who says with primary care visits, they're going to start collecting genomic data. The other thing is, I love the quote from their CEO who said, our goal is to eliminate all waiting rooms within the health system. And really what he was talking about is redesigning it's design thinking, right? So it's redesigning it from, hey, we designed wait rooms because we designed the entire thing around the physician, and the patients can wait. And we have a limited resource of physicians. And what he's saying is, we're going to redesign it. And it doesn't necessarily mean that you're going to put additional burden on the physician, but you're going to do the design thinking to say, all right, well, how many of these visits, is it 60% of these visits, they don't even need to be in that room at all. And we could just push these back into the home or on the device. So if you're putting a team together to think about this, you're bringing together, who would you bring together? So we've got $5 billion. We're going to redo this in Southern California. What kinds of different groups or different thought processes would you want to encapsulate as we try to design this new thing?
Yeah, you want to build solutions, not just fragmented pieces of technology. So one, of course, which is sometimes underutilized, is the patient. My friend Lucy Nanglin often notes that patients included. He often is one of our core faculty at Exponential Medicine. That and I went through the Stanford Biodesign program as a fellow. You need to really understand the condition, whether it's type 1 diabetes or how to manage lung cancer, with the perspective of the patient, the payer, the home environment. So it would be, I think, useful to run through these sort of design elements, thinking about from all sorts of angles, playing out different scenarios, and then how would you integrate some of the new and emerging data and information streams that are going to come, so that you could do things just in time, continuously, proactively. The idea of digital empathy. How do you send someone home, after their total hip or total knee, give them gentle questions and nudges and encouragements, which also enables you to pick up that they might have a clot in their leg that might lead to a pulmonary embolism. Lots of lessons that could be learned and pulled together. So you need a multidisciplinary team, nurses, patients, docs, the CIO, the CMO, to think about putting together a system that connects and is less fragmented. That's what's so frustrating for clinicians and patients. We're spending a good percentage of our time with friction, whether it's getting pre-authorizations or faxing data or filling out the EMR for billing purposes, not for clinical purposes. So really kind of seeing it from all these different angles, and maybe even piloting A/B models and learning what works and being able to iterate quickly.
Interesting. That's awesome. So let's switch gears here and talk about Atul Gawande's new role, JPM, Amazon, Berkshire Health. Great hire for a position, tons of potential. The entity is going to cover 1.2 million employees, as we've talked about. The potential impact is far beyond those 1.2 million employees, because it's going to be closely looked at, potentially modeled as we go forward. So let's break this down in two areas. One is quick wins. One is long-term ways of thinking about it. If you were his exponential technology consultant, what technology should he be thinking about and looking at today to provide quick wins in the area of that 1.2 million population that he's been tasked with improving their health or keeping them healthy?
Well, part of the question is, what do you count as a win, right? In traditional metrics, it may be saving lives or hospitalizations or dollars. So, and one of the challenges with many insurance or payers is they don't have folks for more than a couple of years sometimes. So why are they incentivized to help prevent diabetes from developing, et cetera? So part of what I think is interesting about this new conglomerate, and I don't have any insider information, is that they can start to align certain incentives. I mean, they can hopefully knock out the middleman, the PBM. They can use the engine of Amazon to do just-in-time same-day delivery. Amazon just bought PillPack, for example. So getting just-in-time meds and sort of some of the mechanics of now that have been worked out from the consumer angle can come to some elements of healthcare delivery when it makes sense, particularly bringing things to the home environment. Everything from the Amazon Alexa, help, I fall and I can't get up, or Alexa, make my doctor's appointment, can be done in that system. Obviously others. So part of it I think is interesting is they can start to align incentives and redesign some of the care pathways. Some of the quick wins I think would be, how do they get an interesting pace and engagement of their hopefully healthy members, often earlier in their life realm, where they can make a big difference and prevent the need later for treating cancers, depression, a number of other issues, and get folks measurably healthier on the precision wellness side. I think that's, and being able to use some of the tools that, let's say, Amazon has learned, and the Berkshire Hathaways, to think about saving for dollars. The number one cause of bankruptcy in the U.S. is medical. So there's some interesting, probably other elements beyond the Amazon side that can get folks thinking about how do they think about longevity, there's saving elements in there as well. And then I would, on the exponential side, make sure that they're mapping out some of these technologies so that they're building a platform that can grow. Like, oh, we forgot the silo for personal genomes. That wouldn't be a good thing to miss. To think about, leveraging voices they're already doing, taking some of the digital breadcrumbs that Amazon is good at, and offering the right services to the right people. The idea of a digital concierge for health and for therapy, I think is all some of the potentials in there. So it's going to be super interesting. And I think, even though it's only a million or so members, it can be a proving ground for things that could expand even to some folks think a national health plan that other countries have as a norm. Yeah, it is. I think there's a lot of potential there, and I'm really looking forward to seeing where they go with that. Unbelievably, we are at the end of the show. I've promised to end this on time. So, I want to thank you for coming on the show. Is there a good way for people to follow you? Yep, I'm on Twitter at Daniel_Kraft, Kraft. You can find me at danielkraftmd.net. Exponentialmedicine.com has a ton of content from our conference, which is free to take a good look at and dive into. And I would encourage everybody out there, whatever role you might be in healthcare, outside of healthcare, to start being not to say an early adopter, but playing with some of these technologies. You can get a certain wearable and see if that impacts your behavior, a connected scale, look at your microbiome, your personal genetic information, start to share it with your clinician or CIO and see if you can catalyze them to implement some of these things and open people's minds to what's here and what's coming, because the future is coming faster than you think. Yeah, and so you still have spots open at the conference, I assume? We sell it every year. It's an application process. We don't want to have all pharma or orthopedic people or dermatologists, so we kind of curate a very interesting mix, but we still have some room. It usually fills up by early fall. Exponentialmedicine.com, and has everything you need to know. And you've been there. Hopefully it's changed a bit of your mindset about what's possible. And my favorite thing to see happen is people's eyes and minds open to, again, what's already here, what's possible, and the ways we can collaborate and converge and catalyze health and medicine in new ways, and not always waiting to invent it here or to cross the dots around the planet in a faster and sometimes an exponential manner. Yeah, and obviously great presentations, but I found the conversation in the halls and whatnot just to be just really exciting to talk with. Across the board. Money people, entrepreneurs, pharma. It was just really fun conversations. Plus drumming circles, silent disco, beach runs, meditation. It's a bit of not your usual conference as well. Yeah, and the hotel is historic, and it's worth going just to spend some time in that place. It's amazing. Awesome. You can follow me on Twitter at @ThePatientCIO. My writing on the Health Lyrics website. Don't forget to follow the show on Twitter, This Week in HIT, and check out the website at thisweekinhealthit.com. Catch the videos on our YouTube channel. Easiest way to get there is thisweekinhealthit.com/video. Please come back every Friday for more news, information, and commentary from industry influencers. That's all for now.